help. Oh, way to go, Joe. I got it. Yes, Vernon.
You're muted, Vernon.
You're muted.
My apologies. I just had this pop up, and I believe everyone has it popping up also. This meeting is being recorded. You either have one option or two options. You got it, or to leave the meeting. I don't want anyone to ever feel like that they have no other option than to leave a meeting. And I'm glad that that provision was given. So thank y'all so much for this robust conversation.
You're very welcome. I'd like to move on with our agenda. Looking forward to our presentations and other reports. So the last one is that behavioral board comments on the MHSA annual report. I understand we're moving along with that, and I am looking for Allison to make a statement.
She had to leave.
What?
Okay. Oh boy. I told her that if she did have to leave by that time, that I would address the comments, but I don't know how I'm going to do this because I don't have them in front of me. So why don't let me see if I can get my pull her comments. She wrote up what this has to do with is Allison formed an ad hoc on Mental Health Services Act annual report. So it'd be our comments on the annual report. And I met with her and we came up with a small list of suggestions for the annual report for the program. And she has that list and she emailed it to me, but I just don't know if I'm gonna be able to pull it up quickly. So what I'm gonna suggest, since she's off anyway, is that we go to another item, preferably reports. I'll see if I can pull it up. Otherwise, I'll try to go from memory, which could be very dangerous.
So I want to kind of agree. I want to move on with this. What I got from her is information. Calling it recommendation seems a little bit earlier in the process, and particularly since I would like to see this as a written report that members of the board can read, and then we can discuss the recommendations on it. So I'm going to move on.
Hey, Tim, before you do that, do you have it in front of you?
Yeah, I do.
Okay. Yeah, you're right. At this point, they are tentative recommendations. What Allison wanted to do was present these as kind of food for thought to let you know what we discussed. She wanted to ask any of the board members that have reviewed the annual report to throw out any kind of brainstorm any other possible recommendations. And then Kathy Rigby is having a meeting on Friday to present comments that she's gotten. Kathy, correct me if I go off base here. And then once we've heard that, I think what Allison wanted to do is actually then have a present recommendations to the full board, discuss it, and then vote. So
yes, that's what she told me.
Okay, so if you're agreeable doing this, which would save me maybe stumbling around looking for that email, would be if you could just read those 5 or 6 items out to the group.
I will, but I'd have trouble clarifying them. So bullet number 1, community services and supports, 76% with 50% or more for FSP. What does that mean?
I don't know on that one.
That's where I think let's have something more complete mailed out ahead of time on this. Okay.
Why don't you just go through the list? If we can't clarify that. Does that have anything to do with AOT?
I don't see us there. Oh, a non-billable under that's another non-billable services for individuals in the assisted outpatient treatment program. Another bullet is mobile response team visits to residences. Another, a larger bullet, prevention and early intervention, 19% with 51% serving those who are 25 or younger, or their parents, caregivers, or family members. A sub-bullet is pregnancy and postpartum support for public health. Back to a larger bullet is innovation. The sub-bullet is early psychosis intervention plus. Another larger bullet is work-based education and training. A sub-bullet, supervisor training a minimum of 80 hours within the first year and 20 hours each following year. Another sub-bullet, all staff, tribal, cultural competency/humility training. The last larger bullet is capital facilities and technology needs, in brackets, a minor positive upgrade to the crisis unit or SV, the cafeteria art room. So I do think that needs to be fleshed out and presented in a more formal way for our next meeting.
Okay, I'm struggling hearing that. I know what some of those are. There's a couple I'm not sure about. But I guess what I could say before we move on is just, if everybody has that, to take a look at it, and several of those are pretty clear suggestions, some of them aren't, but it gives you an idea, at least what we discussed, and I'm sure other people, if they read it, will have maybe some ideas. And we recognize that some of these things may be problematic in terms of doing them, but some of them may be doable. And just leave it at that. And I just recommend people read that annual report and annual update and be prepared at the next meeting to bring in anything that they have, unless they have something now. Because at that point, to keep the department's process going, we have to provide some comments.
Okay, thank you. A hand up from Kathy Rigby.
Yes, I just wanted to remind you all that there is a timeline associated with this. I will need to hold my public hearing no later than the end of June. Prior to that, there needs to be a 30-day public comment period. So I would really, really encourage you all to get any comments or recommendations to me no later than your next meeting in March. If it goes past that point, I will not be able to meet my timeline to get this to the state. So thank you.
Thank you, Kathy. Another hand from Katie, member of the public. Katie. I see your hand up, Katie. You have something you want to comment on? Okay, sorry, we missed you, Katie. I do want to then move on.
I'm so sorry. I was muted. I just was going to say, I'm not sure if we're talking about the MHSA plan or the BHB annual report.
MHSA plan.
Okay. All right. Thank you so much.
You're welcome. So finishing action items, we can go back to communications, which is item number 5, an opportunity for board members to share information, ideas they want for the whole board to hear. Hey, Steve.
Yeah, thanks, Mr. Chairman. I received a letter from Mad River Hospital last week, and they continue to have a lot of problems with 5150 issues and numerous other things because their facility is not really set up very well for handling all these things. And so they wanted to have a meeting, and I thought it would be good to agendize this for next month for a discussion. And in particular, Emmy has already reached out to me and is going to be contacting Mad River and setting up a meeting so they can discuss how to make improvements. So I think that's great. Thank you, Emmy, for that. So I think what will be best here is to simply have DHHS reach out to Mad River, work out the details. If they need my involvement, I'm here to help, as well as Supervisor Wilson, that's in his district. But we really want to smooth these things out and make sure that people at Mad River, the healthcare workers, aren't feeling endangered and threatened, and that we're working well together on how this system works. So I don't want to go into all the details because it's not on the agenda, but I would request that we have an agenda item next month and get a report from Emmy on how the meeting goes with Mad River and what actions are being taken to improve the situation. It's come up multiple times since COVID. COVID's definitely made it more difficult, but I think that if we put our heads together, we can probably make improvements. So thank you.
Thank you, Steve. I agree. Let's put that on the agenda. I guess what I'm asking you and Emmy and staff to bring something written down specific that we can review. We don't necessarily have to act on it, but something that we can review. And if there's a recommendation from there, we can do that. Is that all right?
Yeah, absolutely. I assume that Emmy and staff will be doing that, but and I've already forwarded to you the letter from Mad River about the issues. So those could be used as background. And then perhaps Emmy can provide a report updating what actions have been taken, what agreements have been made, that kind of thing. It's definitely been a big issue. And I know it's an issue at St. Joe's. They just have a more modern facility where they're able to separate patients a little bit better. Mad River has no ability to do that. So anyway, I will work with Emmy to make sure we've got something good for the agenda. Thank you.
All right. Thank you very much, Steve. Communications from other board members. Mr. Ash.
Yeah, I just want to say I was copied on some of those emails, and I think I just made the offer. I don't know. I mean, I really think that this is best resolved, that really there needs to be a lot of discussions between the department and hospitals, but I do think it's important that, well, I just wanted to offer to DHH admin, if there's anything that we can do to help in any way. I think this is definitely an area where I know personally as a board member, I would like to know what's being discussed. And that it's a very important issue to the entire community because it affects what law enforcement does with people, how they handle them, where they're going to take them. It affects the people that are on the ground in the hospitals that are dealing untrained with people in crisis in a really bad environment. As Steve mentioned, Mad River, you could have a person in psychiatric crisis that is one sheet away from somebody that just came in with a traumatic injury from a car accident. And the one thing that it's my only thing I hope happens with these discussions is recognizing what Steve said. This is a regional issue. It's an overall community issue. And I really think there are some potential solutions that I hope people look at that involve collaboration. Maybe some agreements between the hospitals. And Emmy, what I would suggest that you guys Google empath. I think it's spelled EMPATH. And I may have that wrong, but it's findable. But I listened in on a legislative hearing a couple of weeks ago about LPS, and they got a presentation about these empath programs, and what they do is, and this is my suggestion, is besides collaborating, this is our new reality with the amount of beds that are available. Maybe we can get more, but in the meantime, the hospitals need to be modernized, and what these empath programs do, and I'll wrap it up in a minute, they are specially designed units in the hospital. They're designed as for people in psychiatric crisis. They have trained people, they have an environment that's set up for it, and they're separated out both for privacy and safety. It's very traumatic for these folks in the ERs. And it's set up so it's less traumatic, it's safer, it's easier for staff. And they're doing it around the country in various places. So I'd like us to at least talk to these hospitals and see if they'd be maybe up for doing it, maybe at St. Joe's, and have people bring them to there. Anyway, that's it.
Thank you. I think the scope of this, the complexity of this needs to be addressed, and a larger group on growing, I'm not sure, because it is a big issue, but very, very important. Any other communications from board members? Laura?
This follows, it's just the question I asked last time. What is DHHS's plan to reduce the impacts of mental health patients overwhelming the ER? So I'll just ask it every month. What's the plan is, and that ties in with what was just asked. Thank you.
Okay, thank you, Laura. So we'll move on with the agenda, which brings us back to number 6, the presentations. CIT, Crisis Intervention Training. I've asked Tim Ash to give some history. He's been very involved with it for a long time. And then for Kelly Johnson, who's in charge of overseeing what's happening right now. So Tim, ask you to start.
Okay, I'm just going to try to give just a real short intro. Kelly is living it, among other things, day to day, and has a really nice PowerPoint with a lot of detail in it. But I guess just what I want to say real quickly is that CIT is Crisis Intervention Teams, and it's some people think it's just training law enforcement. Really, it's doing that, but it's also working with other collaborating folks in mental health, and it's also goes beyond that, and it's developing policies, infrastructure, like what I was just talking about, the empath program, so they have a quick turnaround potential at a hospital for law enforcement.
Tim, you're getting a little garbly. Can you get closer to your microphone?
Okay. It's also infrastructure. They work collaboratively to develop infrastructure in the community that's more effective in dealing with people in crisis. And the CIT started after an incident in 1987 in Memphis, Tennessee. There was a young man who was on the street, psychiatric crisis. Law enforcement responded, and the end result was a tragic death. And the community got together and said, we have to do something. It was NAMI, it was the Memphis Police Department, Memphis Mental Health, and University. And they put together a program to train folks and to collaborate on dealing with folks in crisis. And they became kind of the hub and started an organization called Crisis Intervention Team International. And they've been putting conferences on for quite a while. And they helped develop curriculum for the trainings, and it's spread throughout the country. It's in through our country and other countries. So that's just the short of the organization and the movement. And then just quickly for Humboldt County, we started in 2006. I think it was Sherry Lynn Moore, a woman with was in psychiatric crisis, was in grief because of the death of her son some years earlier. She barricaded herself in her room, and law enforcement responded. They negotiated some with her. They were worried, she had a flare gun, and ultimately they were worried about a fire, and they entered her room and they shot and killed her. And the community, the Board of Supervisors said, what can we do? Mental health wanted to figure out what they could do. The coroner suggested there be better training, and NAMI, local NAMI, asked for it as well. So the Board of Soups and DHHS said, let's do it. Let's see what we could do about this. And they sent a group over to Reading to see some training that was happening. They sent a person from EPD, from NAMI, and from DHHS to a conference to learn what other people were doing. And a year later, we started trainings, or 40-hour, 32 to 4-hour trainings with law enforcement, mental health, and others in the community. we started a working group on curriculum and getting all the people together in 2007. And I think Kelly can take over from here. She can tell you about the success and the nuts and bolts of the program. But it's a great program, and I really believe it saved lives. And it's not only saved lives, the purpose is not only safety of the community and officers, but also to divert people away from the criminal justice system that are having problems that really are related to their mental health issue, mental health diagnosis. So it's very successful.
Thank you, Tim. Kelly.
Great, thanks, Tim. And as we discussed earlier, feel free to jump in on any of my slides. I have quite a few slides. I know I have a short amount of time, so I will do my best to go through them as quickly as possible, so there will be time at the end for questions. I also just want to acknowledge that I was a month early and thought I was presenting last month, my mistake, so sorry for that confusion. So I'm going to go ahead and share my screen. And just 1 second, here we go. Okay, so as Tim discussed, we have several partners involved in Humboldt County's crisis intervention team. So these are some of our key players that are very involved with the badges there. So you can see HSU, probation, Arcata PD, Eureka PD, the Sheriff's Office, District Attorney, the Public Defender's Office, and also obviously DHHS is the lead, and NAMI is a huge part of that as well. So crisis intervention teams are local initiatives designed to improve the way law enforcement and the community respond to people experiencing mental health crises. The key words here are strong partnerships between law enforcement, mental health providers, and families and people who have lived experience. The goals are to improve officer and consumer safety and to redirect people from the criminal justice system that have mental health disorders. All of these things are very important parts of CIT: relationships, community engagement, our systems and infrastructure of services, partnerships, advocacy, leadership, empathy, and you. So I looked for updated numbers for this problem statement. They're not available, but these are numbers I got from the Bureau of Justice Assistance. And let me just minimize here. So as you can see, there's quite a few people with mental health disorders represented in the criminal justice system, in prisons and in local jails. And not all of those folks are able to receive appropriate mental health care while in custody. We also know that there's a significant number of fatal police contacts with people experiencing mental health disorders. Here are some statistics that were available. Again, I looked for more recent numbers and wasn't able to find those. There is a cool website you can look at on the Washington Post where they track numbers there as well. So history, we know deinstitutionalization started in the 1950s through the 80s and continues today. And that continues to be a problem for behavioral health systems of care across the country. And there's continues to be a lack of appropriate funding for behavioral health services in the community, which is why, and lack of beds, as we discussed earlier, there aren't enough treatment beds available, enough funding to support extensive levels of care in the community to keep people out of institutions. So folks end up in the criminal justice system, unfortunately. This next slide, I borrowed it from Stacy Curry at North Coast EMS. She is a 5150 specialist and works closely with us and our partners with the hospitals. But this is from 5150 training that we use for our hospital emergency department physicians. So I'm gonna let it play itself. It should have some volume. Let's see if it works. It does not. Okay, let me try.
Kelly, could you say what 5150 is?
Sure. A 5150 is a 72-hour, or is an application for a 72-hour hold or evaluation for an individual experiencing a mental health crisis. So they have to meet one of 3 criteria: either danger to self, danger to others, or grave disability, which means inability to care for oneself. And it has to be due to their mental health disorder, and there has to be imminent risk of danger. And so that's the first step in the process. That's the W&I code, or Welfare and Institutions Code. And there's several other codes that would be a whole presentation on its own, but that's it in a nutshell. Let's see if I can get this. Here we go. The slide's not going to play the way that I wanted it to, but what I wanted you to see here is the map of psychiatric beds in California. And as you can see on the first map where it says adult psych beds, all of the counties in blue are counties that have psychiatric beds. And you can see that none of the surrounding counties around Humboldt have any psychiatric beds. We have 16 in our county. And then you go to the next slide, or the next map, and it shows children and adolescent beds. And you can see we have none in northern. Oh, why is my slideshow going ahead? There we go. There's very few beds for children and adolescents, none in Northern California. And then you add when there's co-occurring substance use disorders and psychiatric, there's even less. And then you look at the geriatric and elderly psychiatric facilities, and there's only the 2, one in San Francisco, one in San Mateo. So when we talk about placement and trying to find beds for people that need psychiatric care, it's very difficult, and it's only gotten worse with COVID. Facilities across the state are limiting capacity. Their COVID mitigation strategies don't allow them to accept as many people. This has been a major barrier for all counties in California. And I'm sure in other states as well, but I know about what's happening here better than other states. So Tim already talked a little bit about the background of CIT. It grew out of an incident in Memphis in 1987. NAMI is a huge part of CIT. We talk about it being the 3-legged stool, which includes law enforcement, behavioral health, and NAMI, or family advocacy. So at the numbers that I was able to, this may have been updated. I could not find updated numbers, but across the country, there are 47 states and approximately 3,000 CIT programs. There are some states that have legislation to mandate the 40-hour training. There is some controversy or difference of opinion about mandated training versus voluntary training. The model was really meant for people to voluntarily participate in training as opposed to being voluntold. And the reason for that is we want people that actually want to learn to participate in this training. And you can't force people to learn something that they're not interested in. I will say in our county, the majority of our law enforcement agencies delegate who goes to the training, and they are not typically people that volunteer themselves. So it's a work in progress. So the Memphis model is what they refer to as sort of the gold standard of CIT models. The key characteristics of this surround community partnerships, specialized training for law enforcement with an emphasis on de-escalation and diverting from the criminal justice system when appropriate and possible. So CIT steering groups and CIT coordinators are responsible for seeking funding and leading the coordination in the community, as well as leading the training and doing outreach. I have been the CIT coordinator since 2017. I started being involved in CIT in 2015. And we have a robust steering committee that has representatives from several law enforcement agencies, as well as NAMI and behavioral health. The core elements of the program, this comes from CIT International, which is the model that we follow. I'm not going to go into depth just due to time. I can send out more information if people are interested. Again, partnerships, community ownership, and having clear policies and procedures. Having an actual team, which we don't have a specific dedicated team in this county. We have multiple programs within DHHS, and then individual law enforcement agencies have their own protocols. We spend a lot of our energy on training and trying to build those partnerships so that we can have a more consistent approach throughout the different law enforcement agencies in our community. And then having a mental health receiving facility, which for us is Semper Virens, emergency services and first responders, is a huge part of the focus of CIT as well. The sustaining elements are focused on evaluation and research, in-service training, recognition and honors, and outreach. So for our local CIT training, we hold it once a year. Typically in October. It's a 40-hour training. We do evaluate the training. We have pre and post tests that track what people learned in the training, and then we do evaluations for each presentation all 5 days of the training. We'll occasionally do smaller in-service trainings for individual departments as requested and appropriate. And then recognition and honors are very important within CIT. So we want to recognize people that are really embodying the philosophy of CIT. Outreach, I've met with other counties, both Mendocino and Del Norte County, trying to work with them in developing CIT. As far as I know, none of our surrounding counties have a CIT program. And so I often get requests from outside counties wanting to send people to our training, but our training slots are limited. It takes an incredible amount of DHHS staff resources and time to put on the training each year. So unfortunately, we're not able to offer it to other counties at this time. So Tim already told you, so they went to Reading in 2006. We had our first local training in 2007. We've since trained 496 people. The majority of the participants are law enforcement officers, although occasionally we'll have other community providers, as well as a couple slots each training for behavioral health staff, excuse me, to attend. For the last 2.5, 3 years, I've been hosting monthly CIT review meetings. This is part of the recommended model where you bring together stakeholders and to discuss situations, to problem solve together, as well as network and get to know who the key players are. So we were meeting in person prior to the pandemic, and now we meet online. And we have a wide variety of different community-based organizations attend, as well as law enforcement partners. We also have the monthly stakeholder committee meetings. That's our steering committee. So we oversee basically the plan for our training and to make sure it's really not a DHHS led endeavor. It's really meant to be law enforcement led. In our community, we haven't had a law enforcement agency take the lead role in organizing CIT. So DHHS continues to be the lead, although I really try to make sure I'm not the one making all of the decisions. So I know we have a couple people here in this meeting that are part of this stakeholder committee, and we focus on the ongoing collaboration with partners. We developed our own, I'm getting close to the end here, I know I'm running out of time. Our own vision statement for our local CIT. It is a collaboration between DHHS behavioral health, law enforcement, and the community. Together, we work towards increasing public safety and improving outcomes for people experiencing mental health crises through education, advocacy, and outreach. I also wanted to share that CIT International put out this great guide in August of 2019. I was able to obtain a copy of it at the annual conference that year, and they have a web guide or a PDF version of this online, and it can tell you everything about how CIT is supposed to work. And so this has been really helpful for me in kind of bringing our CIT training up to speed with the current standards across the nation. And so I've been slowly kind of improving the way that we run our CIT program. We did increase from a 32-hour training to 40 hours 3 years ago, which is the national standard. We also that year implemented a new curriculum that was developed by the Bureau of Justice Assistance. And this was really important because we had a great curriculum before. It was a very Humboldt style model of kind of focusing on what our individual communities' needs are. But what I learned through my CIT training, coordinator training, as well as I've now been to 6 annual conferences, and then reading that guide, was that we really needed to have a structured curriculum that's in line with what's being used across the country. And so we've implemented that. We've run the training twice now with the curriculum. We missed a year in 2020 due to the pandemic, unfortunately. We did host our last training just this past October in person. This is the schedule. I know that this is difficult to read. If people are interested in receiving a copy of it, I can send it to you. But it covers all of the modules that we cover. So the CIT overview is an expanded version of what I'm doing right now. And so I co-lead that with a lieutenant from the sheriff's office. We cover culture and, we have several DHHS staff, licensed clinicians who help with training, as well as several other providers in the community. But we cover culture and mental health, depressive disorders. NAMI leads a great family panel where they have family members come and talk about their personal experiences with their loved ones and having contact with law enforcement. We cover bipolar disorders, psychotic disorders, and schizophrenia, personality disorders, liability. This is led by a law enforcement person that is able to talk about why CIT is important and de-escalation in terms of liability concerns. We cover psychopharmacology, neurodevelopmental and neurocognitive disorders, disorders in children, youth, and adolescents. Prior to the pandemic, we were doing site visits, not only to behavioral health sites, but to other community providers. Due to the pandemic, we weren't able to do that this last year. So what we did is had the different providers come in and do a brief presentation about their services. We cover substance use disorders, disruptive impulse control and conduct disorders, suicide assessment. We spend quite a bit of time doing scenarios and role plays. These are led by law enforcement, teaching the hands-on training on how to actually implement these de-escalation strategies. We cover assessment, commitment, and legal considerations. We have a guest speaker come from out of the area. He was a cop for a long time in Marin County, and he also became a marriage and family therapist. And so he has sort of a canned presentation that he does. I like to call it CIT in a nutshell. So he covers one whole day and covers a lot of different topics, but he delivers it in a way that is really well received by law enforcement. We also have a module on veterans and homelessness, incident review, and then lastly, CIT in Indian country, where we talk about specific issues related to Native American populations and their interactions with law enforcement, as well as resilience in Indian country. I know that was a lot of information, and now I will open it up for questions.
Tim, you're muted.
I see a hand from Tim Ash.
Actually, I just took that down because I have no questions.
I see a hand in
Sorry.
from Sonia.
Yeah, thank you. Kelly, I might have missed it, but was there a special module on the TAY population?
There used to be, and there's 2 modules that are specific to youth that is focused on the behavioral health disorder or mental health disorder that they may experience. But there's not a specific module on TAY. TAY has been invited to do presentations during the site visits. This past time, Jeremy Nilsson was the one that did that presentation.
We have also have had a little trouble doing this. We've done it once, but to have like 1-day refreshers, and we have talked about having a like a half day addressing special issues like TAY.
Yeah, thank you so much. It would be neat to try to revisit that integration of approaching TAY youth.
Yeah, I would love to talk with you more, Sonia. I know that there was some challenges the last time TAY was invited to present. They declined to present after that. So I would like to figure out how we could remedy that situation.
Yeah, that sounds good. I remember it briefly. It was right when I started as a supervisor. So let's reconnect.
Sounds good.
Great. Great. Thank you. Other comments or questions from the board?
Tim, this isn't a question. I just wanted to say something. I don't know if there's going to be questions, but I just want to re-emphasize that, and I think I'm speaking for families, for NAMI. I think you'll confirm this, Tim, that we cannot say enough about how thankful we are that this community pulled it together and put together the CIT program, the amount of support from DHHS in developing it and maintain the care and maintenance of the program. As Kelly mentioned, often it's done by law enforcement when you have big agencies, but DHHS is toeing the line on that one. We've got a buy-in from law enforcement. Arcata Police at one point had every officer trained. And we think that's important in a rural area because you can't call a specialist. You got who you got. And then the Community Correction Partnership has financially supported it. Just the entire community has done this. Kelly mentioned 500 people have been trained, and it saves lives. It creates empathy and understanding. The law enforcement people that are meeting people in crisis. I don't know what to say other than it saves lives and it keeps people out of the criminal justice system.
Thank you, Tim. I saw a hand from Laura.
I was just going to ask if that PowerPoint could be shared with us. Thank you.
What I'll do, Laura, is I'll send the PowerPoint as well as a few other resources that I think would be helpful.
Thank you so much.
Yeah, send them to Joe McManus and then everybody can get it.
Will do.
Hey,
Thank
Kelly,
you.
do we have an electronic version of the handout for attendees?
Which one?
Just, the handout of when we hand them the binder.
Yeah, I have some handouts that I'll include.
Okay, great. Thanks.
Yeah.
Thank you. I see another hand from Sonia and then from Melissa. Sonia?
Oh, that was my hand from before. Sorry, Tim.
Not a problem. Not a problem. Alyssa. And then Isabella.
Okay. Hey, Kelly, how you doing?
Hey.
I've been trying to get more information on CIT since I first heard about it several years ago. I think being on the board provides a possible really great opportunity. I was hoping, is there any way that we might be able to get in on one of those smaller monthly touch-ups? Is there any way to be able to participate and learn a little bit more about CIT?
The touch-ups are provider meetings where we discuss individual situations that people are struggling with. And as a community provider, you would be welcome to attend that.
Okay.
So if you want to shoot me an email, I can put my email in the chat and I can forward you the invitation.
That is wonderful, Kelly. I would love to be a part of that. Thank you very much.
You're welcome.
Thank you both. I thought I saw a hand from Isabella.
Thank you. And thank you, Kelly, for your presentation. I'm not as familiar as I should be for with regards to the CIT training, but I do have a question. I empathize with the fact that space is limited. However, if we were to encounter other providers, I may be speaking for myself, who want to engage in that 40-hour session, how would one go about that?
Yeah, shoot me an email. What I do is I hold a wait list for non-law enforcement. We prioritize the 40 slots for law enforcement. And if I have available slots, then I'll plug in community providers. So we have had a variety of different community providers attend, but I can usually only accept 1 or 2 per year. Just wanting to make sure that we definitely prioritize those coveted spots for law enforcement.
Thank you.
Mm-hmm.
Any other questions or comments? Well, Kelly, I really want to thank you. It was a great presentation, and I hope everybody learned a lot from it, and you're going to provide that other information for those who want to know more. So thank you. Thank you very much. And it could have been my miscommunication with you about not being on the agenda last time. So
it was my fault.
Okay.
I realized that for the fact.
I'd be glad to share part of the blame. So thank you very much.
The upside of it is she didn't have to rush to get it ready this month.
Oh, it was a gift. I get it.
Exactly.
All right, let's move on. It looks like we have enough time to cover most of the other things. So the other agenda item is on reports. And the first one from the DHHS director. Did she need to move on?
I think she may have left. I don't think
Okay.
she's on anymore.
Then anything, Emmy, that you would have, or maybe someone in her staff like Laurel?
I don't have anything on her behalf. Laurel doesn't. Yeah.
All right, thank you very much. Then Emmy, we'll move on to your report.
Okay. Sure. I was going to just touch on a couple points. Actually, I wanted to talk a little bit about CalAIM, and then I was going to hand it to Paul to talk just a little bit about recent audits. I wanted to just share with this group that, and many of you are aware of CalAIM, the kind of reform around Medi-Cal services. It lives in a number of places, but definitely has some impacts within behavioral health. So for behavioral health, Humboldt County has been kind of following along the requirements. We recently submitted our implementation plan, and the 3 main areas that we're responsible to make sure we roll out are the payment reform, a set of behavioral health policy changes, which include standardizing the screening tool and transition tool for clients who come into care and maybe change levels of need during care. That area also includes standardizing the ASAM criteria. We talked about that a little bit before for level of care for drug Medi-Cal services. There's some revision around documentation standards, and there's some kind of required guidance and training to implement those things. And I want to just flag, I know that's kind of a lot of information there. I want to just flag that really this area, the state's intent is to increase access and quality of care and make providers, give providers the option to be more responsive when clients come in the door. So there's not quite so much rigidity around diagnosis and documentation and all the things that can sometimes be prohibitive in just providing the services that are needed when a client shows up. And then the third area that's a big focus of CalAIM for us, behavioral health, is around data exchange and ensuring that we have systems in place that allow for appropriate and needed exchange between providers, including between us and hospitals, so that we're able to really get and share the data and the information needed so that we can have the best continuity of care possible for patients. So I wanted to just say that there's more to come on that, and we can always spend more time on CalAIM. And I'm happy to take questions, and I'm also wanting to let Paul talk a little bit about audits.
I had a quick question then, Emmy, on these changes for the Medi-Cal reforming. Will that basically affect reimbursement income or who we can serve?
So
Or
that
both?
there's a few different things. Yes, thanks for asking that. So the first one I mentioned is payment reform, and that's the issue there is really to change our payment structure, which right now is cost-based, and so cost reimbursement based. And so we only get paid for what we can demonstrate we spent in terms of providing services. The intent there is to create a rate schedule that's broader and more inclusive of other things that need to happen, and allows us to get reimbursed at a rate that really helps us, do all the things that we want to do and provide really good services without worrying about having things disallowed because they didn't fit into a box of what's acceptable costs. So that's I think the reimbursement piece. Did you ask a question about Medi-Cal? I think you had another part to that question.
Well, it was the speed of the reimbursement and then the scope of being reimbursed or payments coming to increase services. I heard you address both of those.
Yeah, so yeah, that's really good. So yes, hopefully the speed of the reimbursement is quicker and the amount of reimbursement is more appropriate in terms of services provided. And yes, changes to medical necessity and having a diagnosis at onset versus being able to have some time to connect and engage and understand a patient before needing to have an actual diagnosis that allows for treatment and reimbursement earlier on in the process, which I think is really helpful.
So I would summarize that as saying we'll be able to help more people faster.
Sure, yeah. We're able to claim for treatment that we do with those that we engage with that we haven't always been able to get reimbursed for.
All right, thank you. I don't want to keep beating the drum on that. You've answered my basic question on it. So I jumped in there, want to make opportunity for other board members for questions or comments to Emmy about this matter. All right, thank you, everybody. Emmy, you have some other, what?
I have a quick question for Emmy. I think it's quick. If you could just give us an update where, as the COVID situation and guidance has been changing, kind of what's new with you guys on COVID, if anything.
Well, so are you talking about the flexibilities?
Yeah.
Like yeah, I mean, there's so many nuances there. I think that a while back now, not immediately, there were a few flexibilities that were eliminated and there were others that were extended. I don't know that there's any, and if there were flexibilities that we needed that weren't allowed, we had opportunity to request those from the state. I don't think I could do a good job of kind of going through the flexibilities right now on the spot, but I'd be happy to have more conversation with you about that or share more.
Okay, thanks.
Thank you. Now, Emmy, you wanted to refer some things to Paul.
I think Paul had some audit updates.
Okay, thanks, Paul.
Hi, everybody. I just wanted to update, give us a little status report. Our final external quality review report is in. So overall, it went really well. I'd recommend to the board that you schedule time for presentation on the outcome of that report and the 6 recommendations that are coming out of that report. Again, the external quality review is an overview of our whole system of care. It's required annually. and is geared towards helping mental health plans to improve upon the service delivery system that they have in place. And then secondly, the Department of Healthcare Services conducted a triennial review audit of sempervirens. So this is one of the many evaluation and audits that we have on sempervirens. So this one occurs every 3 years, and they come in and review our system and including our charts. So this particular audit can recoup funding, bill things that we've already billed if they found disallowances, for instance, in their audit. So the great news this year is that this triennial is that we've had 0 disallowances. So this is an incredible reflection of the quality of the charting and of the care that's being provided on sempervirens. To my entire career, I've never seen a triennial review with 0 disallowances. So it's pretty remarkable. And in fact, one of the reviewers said that our treatment plans for our clients were some of the best that they've seen. So again, just a testament to the level of care and skill that our staff has in providing this great service to beneficiaries in our community.
Thank you, Paul. How much of that material, I see your hand, Laura, would be made available to the board?
Well, I can put a link in the chat for our external quality review final report. This will take you to the California Behavioral Health Concepts website, where it lists all the counties in California in their final report. So you just look down to Humboldt and click on Humboldt, and you have this year's final report. So you can review that there. And then as far as our DHCS audit, triennial audit, we'll have to look to see how we could provide that that final report to you. It may have some protected health information, so we might need to do some modifications on.
Okay, another comment. If there's things put on chat may not be available for people who are not at the board meeting. And so if that information could be channeled through Joe and then he can send it out to anyone, I think that would be helpful. I just saw in the chat that link. So to have that sent out, I think it's not too difficult. Joe, is that a pretty easy thing to do?
Sure, I can get it from Paul.
Okay, the two of you work together. I saw a hand from Laura.
Oh, it was just to ask that question. How do we access that? And I'm very interested. I would love to read the report even after it's redacted, or come and sit in your office and read it. Thanks.
All right, thank you, Laura. Any other comments or questions on Paul's sharing? Mr. Ash?
Yeah, I just wanted to say, really, Paul, you guys should credit yourselves as well, because getting 0 disallowances really shows that you guys have been doing a good job in terms of training the folks up there to chart properly and to make sure that you don't get disallowances. And especially with all the travelers that you come in, and that's a real challenge to get them to, do their charting well. So you guys should be congratulated as well.
Thank you, Tim. Appreciate that.
Yeah.
I'll pass that along to staff.
Yeah, please do. Please do. All right. Thank you very much. Emmy, back to you if you have any other people in your department to share.
Sorry, I was muted. No, but I think that we'll probably move. Is it the AOT update that's next?
Yes, AOT. Jack, are you ready?
Yes, thank you. So we continue to make progress with AOT. A couple weeks ago, we had a implementation planning meeting, and that was attended by several folks. Tim Ash was there, but specifically we had Judge, I'm not 100% of the pronunciation, but Judge Killerin who will be the judge that presides over the AOT calendar, was there. Luke Brownfield, who's the director, I guess, of public defender's office, was there. And so I think that meeting went well. Basically, what we did is we borrowed a policy and procedure from Nevada County on how their AOT process works. And we just reviewed that policy and procedure. And I asked if anybody felt that there would need to be any changes to that policy and procedure. And I think everybody was pretty much in agreement with how that process flows and works. And so we will just incorporate that into our plan for this. And I think that will work well. So EA Family Services, who is our organizational provider, is working on getting staffed, working on getting situated in their building. And so we're having some ongoing meetings with them about when they would be ready to go. And then also working on education and training meetings for the community. So part of what EA would do would be to go to various community agencies and present on the AOT program and process so that we can start seeking referrals for that. So there's knowledge about how to refer individuals to the county for admission into the AOT program. So we are working on getting them up and going on those things. And I think, that's kind of where we're at.
A quick question, is there a way to say when you will be operational? I'm not sure that's the right word, but up and running.
I don't, it's hard for me to say at this point. I do think there's some things that one of the smaller barriers, but one that I think we need to work on too, is their ability to bill Medi-Cal for services that they provide. And we're kind of working on the contract for that. And that contract is a little different than other ones that we've had, because there's other things that we're asking EA to do besides, Medi-Cal billing. So anyway, we're working on that contract, and I would like to have a timeline of when we know they'll be able to bill Medi-Cal before we get going too much further, right? Because I don't want to get people enrolled in this program and then we're kind of, stopped, because of that. So I think that's part of it, but I'm hopeful to resolve that really soon. So part of that involves other agencies like county council and things.
Thank you. Any other questions or comments about the AOT program and process? All right, thank you. Legislative report. I'm not sure. I don't think Nancy is with us. I didn't know whether we had an ad hoc committee ready to do something. What's your take on it, Mr. Ash?
So Nancy's not on now.
Oh, no, there she is.
I thought so, yeah.
I didn't see you right away. Nancy, come and talk to us.
Hi, I'm Nancy Stark. I'm the Legislative and Policy Manager for DHHS, and Joe McManus sent out a written report to all board members to kind of give you a status and some of the new bills that we are taking a look at. Tim Ash will be leading a ad hoc committee for your board. And we will schedule sometime in March to start kind of going over the bills that might be of most interest to your board. Happy to answer any questions. And I guess I would say reach out to Tim if you would like to be part of that ad hoc, and we will get that on the calendar for next month.
Thank you. Sounds good. Sounds very good. Tim, you want to say anything more about your ad hoc committee?
No, I think that covered it all. Nancy just felt that the timing, she was going to have a report at the end of the month. That's some more, well, the deadline for getting bills in, Nancy. And then we'll, like she said, we'll meet in March. And I do have a couple people, I don't recall names, that have already indicated interest on ad hoc, but whatever it is, up till 5, we could take anybody that's interested. And I think you might find it an interesting process to learn a bit. Nancy's very knowledgeable about the process of bills and has a sense of when they're, not really going anywhere and when they are. So anyway, yeah, if anybody's interested, get a hold of me.
And the purpose of this ad hoc committee is to examine these things enough that they may come to the board for our recommendation. Is that correct?
Yeah, what we do is we look at them and then decide what we think we should do. It could be that, and the recommendation goes to the Board of Soups because they take positions on bills. And so we advocate for, this is a bad bill, this is a good bill, this needs amendment, and recommend that they, lobby in whichever way they choose, whether it's to talk to the legislators or have their lobbyists work on it, I think. Is that right, Nancy?
Yeah. All right, thank you. That's what I thought. Thank you for clarifying that. So we have no SUD, DR committee, and then I'd like to move on and wrap up with the chair's reports. I want to remind everybody about our Saturday orientation meeting for new members, and if your member would like to catch up, or we invite you to come and be a part of that. Colleen, are you still here, Colleen?
Yes, I am.
There you are. It says Ruth brought it. You want to be called Ruth?
I know. I shall mend that.
Oh, I just wanted to use whatever name you want us to use. That's all. So where are we, Joe McManus? We voted for application to be sent to the Board of Soups. Where are we on
It's
that?
going to go. It should go to the Board of Supervisors in March. We're hoping for the first week in March.
Okay, first week in March.
Application.
Okay, and as soon as we know that, we'll get right back to you, Colleen, with the material. And as I said before, you're invited. We want you to come participate with our orientation meeting.
I intend to be there for sure.
Good, wonderful, wonderful. So let's bring up this briefly. I'd like a way for ad hoc committees to have a place on the agenda on a regular basis. So having an agenda item that says committees, whether they're subcommittees or ad hoc committees, that's a time you don't have to have a report, but you're there, you're not stuck in some unknown place. And on that, the process of our ad hoc committees, what I remember is we have a criminal justice one. And Laura, you're planning to chair that, correct? And then the legislative issues, Tim, you're planning to chair that, right?
Mm-hmm.
And then MHSA ad hoc committee, and Allison is planning to chair that. Okay, so I just want everybody to know that's what we have going right now. Those are ad hoc committees. You can find out by those chairs, or if you need to get through to me about participating in them, and they will continue to provide us more clarity about what they're doing. I'm excited about this. It's moving along, and I don't think we've done this for a while. I'm very excited about it. I also want to particularly thank Laura for helping spur a lot of this going. Thank you, Laura. I think that's about what I wanted to report on. I thought it's been a good meeting. You have any questions for me? And any wild and crazy statements you want to make before I adjourn the meeting? I'm hearing
this is Debbie. Can you hear me?
Yes, Debbie.
Hi. I do apologize. I know it's been awkward and we're trying to adjourn. Is this a time that I could make a comment?
Yes. What's the comment about it?
Okay. This has come up before and I just wanted to keep it on, and it's about the Treatment Advocacy Center and the IMD exclusion. I wanted to know what the California Behavioral Health Directors Association's position is on the waiver for psychiatric facilities receiving Medicaid dollars for institutes for mental disease is what it's called, the IMDs, that I know we only have the 16 bed, and maybe that's no mistake, but I'd like to know if we could get a position statement at some point about what either our county or the state's position is on the reimbursement for the federal dollars for psychiatric facilities over 16 beds.
Thank you, Debbie. I know you've been on that. It is a very important issue. As you said, it's a kind of a complicated one. My thoughts at this time are to maybe put that together in like a public comment. You can email it to us and then ask for an ad hoc committee to be formed, which you can ask, but it needs to be chaired. You need someone on the board who say, I'm with you and I'll help chair it.
Okay.
Okay.
Who is making that comment?
Okay.
This is Debbie
Oh,
Hart.
this is Debbie.
Oh, hi,
Hart
Debbie.
as
Okay.
Public
Right.
participant.
Gotcha.
And active in the Family Advisory Committee. Thank you. Yes, thank you, Debbie. Everyone else, I want to thank you very much. And with that, we will adjourn this meeting. Thank you and have a good day.
Okay,
Bye.
Take
you
care,
too.
all.
Thank you. Bye-bye.